All right, have a look at this. There is a big resection happening in the second part of the duodenum. Patient's had cholangitis, has had sphincterotomy twice actually, and was referred for removal of a large duodenal adenoma involving the papilla, so laterally spreading lesion. But the problem is that when we have a look around here, and it's just interesting for what's possible and what's not possible, while probably all this is completely possible to resect, and as we go down here you can see probably the biggest polyp some of you ever saw in your life going right down here, and there's the end of it. All that's possible, no problem, and you can see it's possible because we already made a start here, and this part came off very nicely. And that was kind of for me a proof of concept to see if this was possible, because when I started I was having quite a bit of trouble. So maybe I shouldn't have started this, maybe in retrospect, but I certainly have stopped. And I've stopped because I think this situation is unmanageable and will put the patient at risk of significant adverse events without any benefit. So of course the other option for this patient is surgery or leave it alone. Okay, we can't think we can leave it alone because she's repeatedly doing episodes of cholangitis, so there's something about this polyp and the maybe potentially a little bit of introduction invasion. We've never shown cancer here, but of course can always be that it's a little bit of in the mucosa starting to become invasive soon. The issue with this polyp is not how big it is or how much of the circumference it is, because certainly we and many other centers have reported that this is possible before. It's also not that it's involving the papilla, and while cholangitis is a bit of a concerning sign, almost certainly it's possible to treat that area when we're not using any RCP scope right now. But the problem is, if we come back into the duodenal bulb, so we'll just push in here, the first problem is that this part of the lesion is not lifting at all. So probably, if we look at the pathology, this lesion is pyloric gland adenoma, and they are well known for not lifting, having a lot of submucosal fibrosis, and you can see the attempts that I've made to get a snare excision, and when you compare these attempts to what you just saw in the second part, it's not progressing well. And also, it's completely involving the circumference of the bulb here. So this is marker number one, that it's not going to go well. The second one is that up here, as we just traverse, and you can see it here on fast, but I get you a better view because it's very hard to appreciate like that. When we just come back on this area, and it's a shame that it's bleeding, so hopefully we can just at least wash that away so that you can just appreciate for a minute what's going on here. There's a huge amount of scarring happening here. So right dead ahead in the middle of the screen, there's just a huge amount of scarring. And this lesion here at this point is very stuck down. You can see a big fold of normal polyp coming in at the 4 o'clock. Behind that, it is absolutely, it will not lift. It will not lift, and this means that this area of polyp is very unlikely to be able to be cleared endoscopically. In addition to that, the patient, given the complete circumference that is involved, and you see it better here actually, here we're right on the zone of fibrosis. I get a shot of that, there we go. So that is all fibrotic and will not lift, but very clearly contains polyp, certainly at the 9 o'clock, certainly at the 6 o'clock. This patient will get a high-grade stenosis from this resection. This is for sure the case, and therefore all of these things probably suggest that the other option of surgery, albeit potentially relatively invasive for the patient, is a better option here than putting the patient through the risks of a continued endoscopic resection, perforation, delayed bleeding, pancreatitis, and then in addition to that, the stenosis that will develop afterwards, all for which the patient may not receive any benefit. So I think it's important to consider those things when you're doing endoscopic resection and when you're performing such procedures. And I think it's also very important for you to consider those, that sometimes these decisions cannot be made until you've started the procedure, such as this case, I think. Sometimes up front you can tell, but in this case I think those significant features I've mentioned have led to that decision making during the procedure. I guess you need to know when to stop. You also need to balance giving a patient 2 procedures with a load of risk versus 1 procedure with very high risk but which will be necessary anyway. All right, thanks for watching.